All righty. Hello, everybody. Happy Friday. We are here with Angie Lehman today. Welcome, Angie.
Thank you. I'm excited to be here.
So I'm going to start introducing Angie real quick to you guys. I think most people know her, but if you don't, Angie is a certified orofacial myologist. She provides caring, individualized therapy for patients of all ages with orofacial myofunctional disorders. She's passionate and enthusiastic about prevention and treatment of the causes of OMDs rather than just treating the approach to the elimination of oral habits has proven to be very successful. Her expertise includes sucking habit elimination, tongue thrust correction, oral rest posture therapy, and the recognition of tongue and lip ties and their influence on orofacial growth and function. She works in conjunction and is well respected by local dentists, orthodontists, speech pathologists, ENTs, lactation consultants, and other skilled medical professionals. Did I miss anything?
Yeah, you did it beautifully.
Awesome. I am so excited about our topic today. It's going to be wonderful. We are on a little bit of late response. So whenever we ask the audience to tell us something, it's going to take about a minute or two before they receive it. So, okay. And anybody watching today, a lot of times we're not able to see your name. So if you would like us to be able to read your name, please type on the comments your name before your question. So like that, we know who you are. We like to know who's watching and who's listening with us. This is supposed to be interactive, so have your questions ready. You can post your questions in the comments and we'll bring it up so Angie can help us answer them. What else am I missing? Announcements. I have said on Clubhouse that this summer we're going to do Tuesdays Clubhouse. We're going to keep that schedule. On Thursdays, we have a surprise, and we have a bigger surprise on Sundays on Clubhouse. So you guys need to stay tuned. We're going to be announcing it soon. Our Facebook Lives are probably going to stay throughout the summer. We might take 4th of July off and things like that, but I'll keep you guys updated on Airway Circle Facebook group. So the topic today, this ain't your mama's myo. That is my favorite topic. Pros and cons of a rapidly changing field. And that is true. How long have you been doing this, Angie?
This is my 10th year doing it. So I feel like in some ways I'm still just kind of getting started. And I also feel like I've been doing this forever and I can't even remember doing anything else other than this.
And how different is it now from it used to be?
Yeah, exactly. And that's the thing. And that's why, I want to do it together, is because it has changed dramatically in the past decade. And a lot of it is so good. And some of it's not. And so, I keep having all these things like floating around in my head, like, wow, with having 10 years under my belt, there's a lot that I see that I want to really encourage people to continue. Especially awareness. I mean, awareness has grown exponentially in the past decade. But there's also pitfalls. Anytime that you have this huge surge in popularity of something and everybody's hearing about it and people are still never quite certain what it is or what it's intended to treat, then all of a sudden you have all of these people going rogue, and all of a sudden it's kind of a watered down version of the myo that I knew 10 years ago. And so there's some pitfalls too in progress as well.
Definitely. And we do have to be very careful. I mean, there are so many great courses out there. But at the same time, I'm one of those that I don't know if I should share my personal opinion, but
that's what I'm going to do for the next 45 minutes. So please.
I'm one of those that I believe that myofunctional therapy should be practiced by dental hygienists and speech pathologists. Nobody else. Of course, we would love for people to get to know this industry. So just like I want to know a little bit more about craniosacral, I want to know a little bit more about IBC, what IBCLCs do, what OTs do, what speech pathologists do, just so I know when to refer.
Right.
I want to know what you're doing so I can. I don't want to do your job. There's plenty for us to know and to focus on myofunctional therapy. By the way, guys, if you're getting any feedback, please let me know. And if you're watching it live, please type Mama's Myo so I know you're here live. Okay. But yes, we do have, and people just coming into this field, they are at this point now getting a little bit confused. I remember when I was first looking for my course, there were 2 associations that I could choose from.
Mhm.
That was pretty much it.
Yeah. And now it's like
there's so much out
everywhere
there.
you turn, there's something available, which is not necessarily a bad thing in and of itself. It's a good thing because it means that more people are aware of it. But because it's a very unregulated course or field, there's not a lot of monitoring of what's being taught and what's, being conveyed as far as what our role as therapists is. And that's where things start to get a little dicey, don't they? So
definitely. So I cannot wait to hear everything they have to say. So the floor is yours.
So first of all, I have to give a little bit of background of, kind of how I got into this field. So I've been in dentistry. I've been a hygienist since 1999 and loved clinical hygiene, absolutely loved my role as a clinical hygienist, treating my patients in private practice. My brain loved it and my body did not. And so, many years ago, probably about 12 years ago now, I was going through a lot of health stuff. I was having major chronic pain issues. And I all of a sudden realized one day, oh my, I can't continue to do this work that I love. And so it started the journey of, what the heck do I do? And, 12 years ago, I had never even heard of terminology. Nobody was really talking about it. Nobody was really doing it in my area at all. And I literally stumbled into it accidentally because I was reading RDH magazine and I flipped to the back where they have the marketplace and they have the ads. And I saw this ad that said, become a certified orofacial myologist. And how sometimes you just have that feeling that you're just drawn to something. And I literally had no idea what it was, but I saw it and I was like, this is intriguing. I don't even know what that is. So what do we do when we don't know something? We Google it. So I went online and it was crickets, nothing. I could find a little bit of info. I could find maybe before and after pictures. But there was nothing, no information there. So I had to dig a little bit. I had to really look and research. And the deeper I dug, the more I went, this is absolutely fascinating. And I still don't know if I'm quite understanding what it is.
Mm-hmm.
But I'm intrigued enough that I'm going to plot down some money and I'm going to go do this. Because at this point, what else am I going to do? I can't go back to clinical hygiene. So I literally had no plan B. And this became the thing that I have been doing all along anyway. So, I took my first course about 9.5 years ago. I took Sandra Holtzman's intro course. At her house in Florida, there was maybe 8 of us in the class. That's how tiny the field was at this time. Everybody packs classes with 25 or 30 people now, multiple times a year. And a decade ago, that wasn't how it was. It was a lot smaller and a little bit more intimate. And I loved that. I loved that about it.
And do you mind turning your volume down a little bit on your computer? Yeah. And we think that will help. Somebody said there's a very strong echo. You guys let us know. I'm going to turn the volume down a little bit. Yeah. And let me know if that works.
If that doesn't work, I have my mic, my portable mic plugged in, and I can always try to unplug that too and just use my computer audio if that helps. So let me know.
Perfect. I had the same or similar experience when I first found out about this field. I was like, oh my gosh, I cannot believe that there's so much more that I can do for my patients. I mean, being a hygienist is awesome, and you get to, you start getting super close to your patients and they trust you, and you have the ability and the opportunity to really get to know them and to ask them how their sleep is. And, how many patients sleep on our chair, right? And talk about nutrition with, nutritional counseling and all those other things in their lifestyle and what's going on in their lives. So, it's amazing for hygienists to be going into this field.
It is. So not even knew about it. I didn't learn about this in hygiene school. And it was so interesting because when I took this class, I could think back to all the patients that I had been treating for, over a decade going, oh, this is what was missing. This is what they need. These are all those cases that I wish I could go back in time. And now I actually have the answers and I have the tools to be able to treat them. But that was 9.5 years ago, and I haven't looked back since. I literally jumped in with both feet. I took a class, I read and read and read and studied. There was still not a whole lot of info out there, and so it was hard to find other classes. Nowadays, it's fantastic because you can find stuff online. You can take any class on anything that you want. There's tons of literature. There's books. There's a lot of articles that have come out in the past decade. We kind of had to dig a little bit back then. But here's the good thing about that situation is it did force me to crack books open. It did force me to read orthodontic textbooks and medical books and literature that nobody else really was looking at the time. I was pulling articles from all over the place. And it forced me to really dig in deep. And because I was, met with some resistance by some of the medical and dental people in my area, I literally was the first dental professional in Pennsylvania to be doing this. It forced me to have to understand the science behind it and to know it so well that I could convey that as I was, sort of building my team of people that I now work with. And it was a lot of blood, sweat, and tears the first couple of years, especially. But what an impact it's had. My business is growing. We get people from all over that drive to come and see us. And so it's amazing to see the transition over the past decade from where the field started to where things are now. So it's been the best journey ever. So
that is amazing. And thanks to all of you who have paved the way for us, all of this blood, sweat, and tears that you guys have shed, just making it easier for us that are coming now and after, making it so much easier. I mean, we still have to, of course, study a lot, but you guys have definitely done an incredible job into opening the eyes of other professionals into this field. People now are finally starting to listen and getting interested. So it would not have happened if it wasn't for you guys. So thank you.
And that was one of my biggest things. When I started out, I was like, okay, when I did my first search online, I found nothing. And so I have literally made it my personal mission to put out as many before and after photos, to write articles, to teach classes, to help show people in pictures what this field is capable of doing, because I think that's what was missing a decade ago, especially for myself as I was getting into this, is nobody could see what was possible with this field. And so it's cool to see how many people are out there. I love, hopping on Instagram every morning and seeing all of people's pictures of their before and after cases and their graduates and, all the things that they're doing, because it's really exciting.
It is incredible. And everybody's first question is, you did this with myofunctional therapy? Really?
Yeah, exactly. And doesn't it feel good too when you have those cases where you put your photos side by side? And sometimes even when I'm working with somebody over the course of a couple of months, I don't realize until I put their pictures together how much of a difference we really did make. And that is always so cool to see. So, that's one thing I encourage new therapists is always take quality photos. Every single patient, take quality photos of that patient. Make sure that your angulation is perfect, because nothing makes me sweaty worse than when I see somebody's before and after pictures and they're like, look at this open bite that closed. And I'm like, no, that's just different angulation.
Look at the picture isn't like this. I have a little guide that I tell my patients, if they're going to be taking the pictures from home, got to make sure if it's a phone, your phone is straight. You're not taking a picture like this or like this. There's enough light in the lighting in front of the patient. If it's a child, try to get your phone where the camera is in front of the eyes of the patient, far back enough. Yes, photos are so important. I actually was just speaking to somebody here in Georgia. Her name is Melissa, and she called me a few months ago saying, I want to get into this. I'm a hygienist and I'm not working right now. I just stopped during the pandemic. So I gave her some pointers and she started a course and she's loving it. She's like, I'm just so nervous right now. How am I going to approach these other professionals? Because I'm not working at a dental office right now. And I said, well, first of all, start treating your friends and your family and take photos. That was one of the things I told her. Take some good photos, because whenever you have that together with some research studies and you take those to the professionals, they're going to be more willing to give you their time.
Absolutely. And that's what sells my cases too, to families that may come and see me that are still kind of on the fence. I have a whole book of before and after cases that we've treated. And so parents want to know that the money that they're investing into this or anything else is going to be 100% worth it. And so, so that's a really important part of it, is our documentation. So
definitely.
Yeah.
So what else have you noticed? I mean, we're talking about great things that have changed.
Yeah, we are. Yeah. So I feel like, one of the things that I see is airway, the change in awareness for airway, the change in awareness for good breathing, and our role in that part of it, I think, has kind of morphed over the past decade. I mean, honestly, believe it or not, like 10 years ago was not that long ago, but it was almost taboo in certain circles to talk about breathing retraining for some of these patients. And boy, were we missing the big picture when we had that mindset. And so it's nice to see how things have, gone in a positive direction as far as our role in breathing. But I feel like some stuff has kind of gotten lost that was really beneficial. And I think one of the things that I see, one of the biggest mistakes I see that a lot of newer therapists or newer clinicians make is thinking that they can fix certain breathing issues just with therapy and exercises. And this is the one thing where if you don't get airway right, no amount of myo that you do is ever going to work. If somebody has a nasal airway obstruction, or they've got enlarged tonsils, they've got large adenoids, they've got turbinates that need addressed, those are cases that you absolutely have to be teamed up with the appropriate professionals to treat those things. And I see so many times people are kind of like hoping and crossing their fingers that like, oh, if we just teach nasal breathing, that the tonsils are going to magically shrink and that all these things are going to go away. And that is occasionally the case, but in most cases it's not. And so, it doesn't matter if my patients are willing to go to an ENT and treat things, a little bit more traditionally, or if it's one of my families who really prefers to treat things a lot more naturally, I'm going to still be working with other professionals to help address chronic inflammation, to help address some dietary things, some other lifestyle and health choices, because that is one of those roads that you don't ever want to walk alone. And you don't want to overpromise and tell your families that, this is going to magically fix everything, because I've seen a lot of cases where people have not addressed the chronic airway issue, especially chronic allergies, especially here in Pennsylvania. Because I just had a patient
in Georgia too.
Oh yeah, I asked a patient last week what she was allergic to, and she said the entire month of May. There's a lot of people here in Pennsylvania that probably feel that way too. But, we have to be teamed up with the right professionals. And I'm going to be honest, I've taken a couple of breathing courses, but I don't do a whole lot of breathing retraining with my patients. I may teach them a couple of tips and tricks. I may be encouraging them to use their clear nasal spray and to use the regimen of medications that their doctor has prescribed. But I have found that when I treat the muscle dysfunction, sometimes that breathing takes care of itself. I don't have to jump through tons of hoops. And so, everybody's always like, ooh, treat the airway first and do breathing first. Sometimes you actually want to treat the rest posture issue and the dysfunction first while that patient is working with their doctor on making sure that we're reducing the inflammation in the nose. And then we don't have to spend tons of time doing things that aren't really necessary when we do them in the right order. So I'm a big believer in let's do exactly what we need right from the start, rather than spinning our wheels, trying all of these things just to hit a wall and then, still not have great habituation of our patient's oral rest posture because there's still an underlying airway issue there. So I'm a little bit more open when it comes to that. And I'm actually thankful and grateful that I was trained in a time when we were really learning how to treat the muscle dysfunction and not hyper-focus on our role in airway, which I know some people are probably going to want to tar and feather me for saying that, but it is what it is. And I have really good patient outcomes to prove it. So, there's a good side, like the building of the awareness is fantastic. The opportunities for learning for therapists to learn who want to learn about breathing physiology is there. And there's some fantastic courses out there. I've taken a few of them, but that's not the primary focus of what I do. I'm working with the oral rest posture and the muscle dysfunction, and that's my primary goal. I don't care what that patient is in my office for. I don't care if it's a sucking habit, if it's somebody who does have a chronic airway issue, if it's a tongue tie issue. We're going to focus on making sure that we get you in the best possible oral rest posture, especially for kids that are still growing and developing, because that rest posture has so much influence on craniofacial growth and development and how the muscles function. So if we can really fix that underlying piece of it, then we've done our job and we've done it well. And we may not have to spend all this extra time doing all these other things that a lot of people feel like they have to do now. So.
Definitely. And I usually tell my patients, you know, the reason why myofunctional therapy works, it's because I'm not doing this alone. I'm not doing this by myself. I'm working with other professionals. I'm not going to let you just see me. We're going to make sure that, you know, if there are other issues, you're going to see several other professionals. You know, it's a journey, and I'm here to hold your hand and help you through it. And, you know, a lot of times it's going to be a lengthy journey and a lot of times an expensive journey. With a lot of work. I mean, I have a few patients right now that need orthodontic surgery, and my goodness, that is it is a road that they have to go in through. But anyways, I always tell them, you know, I'm here to help you through anything that you may need during this time. But yes, definitely working with other professionals makes a huge difference. So if you notice a patient has certain breathing issues, even after you have worked with the muscle dysfunction, do you have any professionals around you that you refer to for specifically breathing therapy?
Yeah. A lot of it's going to depend on what the breathing dysfunction is stemming from. So, you know, I feel like one of the most underutilized people that a lot of us could have on our team is the allergist, because at least for the area that I'm living in, for a lot of these people, it's just an issue where their nasal breathing kind of ebbs and flows just because of whatever season it is, and when their allergies are flared up. And so getting the allergist on board and helping them manage and control their allergies is an underutilized thing. You know, it's not always the ENT that we have to send patients to. So that, I think, is a really, really big thing. And then actually one of the therapists in my office actually, you know, does some Buteyko. I've taken some of Lois Laney and Rosalba Courtney's courses. And so, you know, we're giving them a couple of things, but usually that in conjunction with whatever their allergist has them doing is enough to really take care of it. And sometimes it does mean surgery at the ENT's office. But those are all barriers that we sort of try to address even before we start. You know, we're good enough at doing it now that we can recognize which cases we're going to hit roadblocks on. And so, you know, usually we're taking care of those things even before we start therapy. And every once in a while, you know, the longer that you're in this field and the more that people know about it, we tend to get, and I especially tend to get, a lot of really complex cases on my caseload. And, you know, sometimes they don't need myo, they don't need breathing retraining, they don't need, you know, nutritional counseling. They need stuff that's like even more basic and fundamental and, you know, more groundwork than anybody else. And so, you know, for anybody who is treating those type of patients that are chronically ill or have chronic issues and they're incredibly complex cases, I took a class with Michelle Chatham online last summer, and it totally changed my mindset on how to address these patients. And so sometimes we're not even talking about myo and muscle dysfunction. Sometimes it's a little bit more fundamental than that. It's getting them in the right light environment. It's making sure that they're getting, you know, some connection to the earth, so their batteries basically have what they need to be able to run efficiently. And if you can fix that foundational piece of it with them, or teach them how to fix themselves, then they may not need all of these other things that we sometimes tend to throw at them. And so those are always interesting cases. Not everybody is ready to go there, and that's fine. But for the people that are ready to do some of the woo-woo stuff with me, then we're going to do it. And, you know, we're still going to get a good result.
That is so important, that myofunctional therapy is not cure for all. It is so important for, you know, it is a fascinating field, but there I have taken some classes there that it was like, oh my goodness, it's 100% it can do this, and it's like, no, really.
You have to be, you have to be really selective in the cases and know which ones you're going to get a good result, which ones you're not going to get a good result, and which ones are worth at least trying and doing the work with. But yeah, it's interesting to see how like my own philosophies and the way that I practice have morphed over the past 10 years too. So, which is exciting.
We have a huge comment over here. Can you see the comments, Angie?
Let me look. Maybe if I click over here. Woo! I don't even know any of these were here. Perfect.
Let's see if we can read this one. I don't know who wrote it, but I have had many patients whose tonsils adenoids have shrunk, often associated with mouth breathing and lack of activation of the posterior portion of the tongue. Agreed that some cases need referral, but many do not. Just had another patient this week whose child was slotted for tonsillectomy, and her ENT said her tonsils look great now. We are not born with extra parts. Excising tonsils adenoids does not address why they're enlarged. I do not know what that means. I think of the enlargement as an indication. Yeah. Is there more?
Maybe.
I guess it just doesn't show us more than that.
Yeah, I can't see the rest of the comment. Yeah, and I understand that, not all of us are going to look at the tonsil issue the same, but I've seen too many times where people have wanted the nasal breathing to really fix the airway issue, and it may make it better, but did it make it good enough that that patient has completely unobstructed breathing? And in some cases it doesn't. And so that's when we absolutely have to pull in somebody else. I've seen tonsils shrink just by, getting lips together, but it doesn't mean that it's going to happen for every single patient. And so learning to be selective and learning to know when to call in the professionals for other things is important.
And there are some, every case is a case. There's some cases that you might not be able to wait. You might not be able to wait, weeks with functional therapy because this child is not able to breathe, or even the adult, they're stopping breathing so many times. I mean, so there are other, you have to look at the whole picture. You have to doctors.
Yeah, that's an excellent point. Yeah, and I had somebody gave me this analogy one time, and I wish I could credit them because I can't remember who it was. But a lot of parents do have that mindset where, okay, I don't want something taken out. It's not an extra body part. Like, we don't want to take it out if we don't have to. And I 100% agree with that if we don't have to, but sometimes it's almost like you look at that child and it's like a house fire, like my parents had a house fire probably 8 years ago now, and it was in their basement. And when the fire department came in, they smashed all the windows and hosed down the entire thing because they had to save the structure. So even though my parents' house fire was contained in their basement and everything was burnt in the basement, there was smoke damage and water damage everywhere else. But when they had to rebuild, it was only cosmetic stuff in the upper part of the house and structural stuff down below. They didn't lose the entire structure. And so, I heard somebody say one time that tonsils and adenoids are kind of like that. Sometimes we look at these kids and it is like a full-on house fire. And if we're going to save the structure, we got to get in there and we're going to bust some things up and we're going to spray some things down, and it's going to look like one hell of a mess afterwards. But we saved the structure. We have intervened and we have put that child back on track. And now we can use myo and orthodontic treatment and all of these other things to really rebuild the structure. So that's how the cookie crumbles sometimes. We cannot avoid surgery for all of these patients, just like we can't avoid orthognathic surgery for some of our patients with structural issues. There's certain appliances that we can do non-surgical techniques, but they're not for everybody. They're not a one-size-fits-all. And that's another thing that I see that, in the past number of years that a lot of therapists have these, like they're really in love with a certain type of treatment, a non-surgical treatment for, whether it's expansion or forward growth of the jaw. There's a lot of really fantastic things out there, and I'm a huge fan of them. But we have to remember that just like with tonsils and adenoids, ortho and non-surgical appliances are not a one-size-fits-all treatment. And so, we have to be really careful, I think, as therapists, speaking out too strongly about what type of appliances our orthodontic friends are using for certain people, because not everybody is a candidate for ALF. Not everybody is a candidate for AGA. Not everybody is a candidate for MARPE. And we have to look at more factors than just whether or not they need forward growth or width. Most of our patients that we look at need forward growth. Most of them need width, but we have to be able to do it safely. And, I don't care what anybody else says. If you have a periodontally involved patient, you absolutely need to be careful about what type of appliance you're using. And so I think if we're too outspoken about like, oh, they have to have this, or we absolutely can do this because it's been proven safe, it has been proven safe in a lot of patients, but not in every single patient. So we be really selective, and we don't want to, bite the hand that feeds us and upset our orthodontic colleagues by saying you should never do this type of appliance because X, Y, and Z, or you should always do this type of appliance because X, Y, and Z. It's different for every patient, so we have to take that into consideration.
Definitely. We do have a question, I think. Let's see. Any comments on excessive digit sucking? Either what age should digit sucking stop, or how much time during the day and night is considered too much time spent digit sucking, or any other comments on that?
Yeah, it's hard to say. Obviously in a perfect world, any child past the age of like 9 months to 1 year, that physiological need for non-nutritive sucking is starting to diminish by that time. And so, but we see some kids who have prolonged habits past the age of 1 that don't have a whole lot of damage because of it. And then we see others that like things are kind of a hot mess. So it just depends on the child. We usually don't start our habit cessation programs on kids here though until they're probably about 4. So we're seeing kids that are a little bit older, and some of them do fabulous at that age. And then we get some kids that, we've treated teens and adults before with sucking habits. So the longer that somebody has that habit, the more intensely they're sucking on that digit, the more often they're sucking on that digit, that is going to translate into how bad the myofunctional disorder is that's associated with that habit. So the sooner we can get them out, the better.
And while we're talking about oral habits, I was just introduced the other day to a new pacifier. And like for years, I've been telling my husband, like he cares, but I've been telling him, oh my gosh, we need to come, somebody needs to come up. I wanted to come up with this pacifier that is more similar to what a breast does. It needs to extend it. I have my OT friend here. Do you know what I'm talking about? The Nini.
Is it one of the shop?
I don't know, but it's called the Nini. Have you heard of it, Angie?
I haven't. No.
So it extends. Like the rubber extends whenever the stuck on it, and the inside is see-through. So if you put in the patient's mouth, you can see what the tongue is doing.
Right, exactly.
I don't know. There's no. We need some research studies to know exactly. But I would have been comfortable introducing something like that to my children.
Right.
Try to prevent thumb sucking.
Exactly. Luckily,
I just heard of it.
For my older two, and my kids are grown, and I've got 2 in high school, one about to graduate, and then I have one that's a Marine. So he's out of the house and gone. But when they were little, my first 2 boys took a pacifier, but by the time they were about 11 to 12 months old, we just took it, and it was easy because they're toddlers, they're barely walking at that point. But my youngest one, oh boy, did he ever try to put those fingers in his mouth. And so I did the mittens, because this was even years before I was in the myo field, but I was like, oh, no.
Much, probably, maybe max 2 millimeters.
Hey, that's 2 millimeters more than you had before.
Exactly. But in the past 5 years, just my tongue up, it has moved, opened up a little bit, but it's still at like 32, 33.
Right.
Molar. And I kind of have, I shouldn't say kind of have, because you either have a tongue tie or you don't. But range of motion is great. Floor of the mouth comes up, but I have so much neck tension and all of that. So I am considering getting released. I just want to release the fascia at least, to see if I I will get a little bit more less tension in my neck and head.
Better range of motion. Yeah,
exactly. But it concerns me because of my molar to molar width.
Right. Right.
So, I mean, it's a journey if I want to do MSc or MARPE or, and then I've had septoplasty done.
Okay.
And then I know that some doctors don't like to do surgical expansions if you've had nasal surgery done before, but not every case. So we'll see. I don't know yet what I'm going to do, but definitely if you see a picture of me as a young child, huge bags under my eyes, mouth breathing. I had allergic rhinitis. I mean, all of the issues. It was always sneezing. And after Mayo, I mean, sleeping with a mouth open, my siblings would take pictures of me while I was sleeping. Oh. So mad. But I did. And long face, you know, gummy smile. And I feel like most of us that go into this field is because we had a little bit of a personal experience that we don't want other people to have to go through.
Right, exactly. That's like the common denominator for a lot of different therapists is like they've realized that they had their own dysfunction and then went, oh my gosh, like there's something you can do about this. And that's how they ended up in this field. I never had, you know, I've always been a nasal breather. I've always had good tongue posture. I never had braces, you know, so I'm still narrow, you know, if you look at what ideal is, I definitely don't have as much width as I should have, but it is interesting to kind of see how like so many people are in this field because they had personal issues or they have their kids that have had some issues. And for me, you know, I do have a couple like personal stories from when my boys were younger because my middle one, I could tell that he was going to need some expansion. And so, you know, I'm a good hygienist. We took him early because I was all about early intervention and we expanded when he was probably in second grade. And he wore his retainers faithfully. Every night he had them in. And yet, like he was having issues with a little bit of collapse and things weren't fitting. And so, you know, we went back to the orthodontist and all they said is, well, he needs to wear his retainers. And I'm like, but he is wearing his retainers. Like he is faithfully wearing his retainers. And, you know, so things continued to collapse to the point where his retainer didn't even fit anymore. And that was about the time, you know, he's 18 now. It's about the time that I started kind of getting into this field and then it all made sense. And I was like, oh, he, out of all three of my kids, he was the most physically tongue-tied where he had that classic kind of anterior tie. It wasn't terrible, but it was there. But he was my easiest one to nurse out of all three of my kids. And so like I never really thought about it because he had no other symptoms. But he didn't have great tongue posture. And so that's why we were a little bit high and narrow. And so we ended up switching orthodontist and getting a whole second round of expansion. And now at 18, he's got beautiful space between his teeth. And, you know, I'm looking at his pan going, we may not even have to do anything with the third molars for him because everything is coming in straight. And so we're just going to kind of wait and see. So, you know, it's interesting to be able to take this and apply it to your own families as they grow. It's probably field when they were younger because I would have been like obsessive about it.
Well, last night I walked into my daughter's room and she was snoring.
Oh,
lips closed, quiet, not moving, and snoring. So I grabbed my phone. I have to record this. I'm like, you know, this is when I showed it to her this morning. She was so mad at me. You recorded me sleeping.
Oh, that's so funny. Yeah.
Like I need to know. And it's interesting. And I might share the video later. I moved her and then she stopped. And then I put my thumb underneath here and I pushed her tongue up and she would start snoring again.
Interesting.
Even though her lips were closed.
Right.
I mean, you could hear the, you know.
Right.
But I'm interested to see what's going to come out of that. Same thing. She has posterior tongue tie, high vaulted palate, no room for 24, 25.
Right.
Like doing munchy, but she's my daughter. She doesn't want to do what I tell her to do, you know.
Of course not. Our kids never you need somebody else to tell her what she has to do. It always comes better from somebody else other than mom.
Nice. We do have another question. Let's see. Oh, related to still the digit sucking. What kinds of dysfunction leads to digit sucking?
Yeah, and it's hard to say. Some kids digit suck just because it is physiologically normal for babies to suck, and it just becomes a habit. So sometimes there isn't an underlying reason that they're sucking, but sometimes I see, a correlation between kids that do have tongue ties that can't get that tongue, up against the palate where it belongs, or kids that do have some airway obstructions that are kind of, propping that thumb in there at nighttime. I think it's probably helping them breathe. And so, sometimes we do see a correlation with those other things.
Very good. Jillian said, what products do you use for tongue to spot reinforcement, like Coloplast, Myospots? I can't get my son past the gagging.
I use nothing. I don't recommend Coloplast. We have a little bit here in the office in case we absolutely need it. The Myospots, I love the product, but I have found that if you get the myo training, if you understand how to train oral rest posture, then you can get that patient to achieve and maintain good oral rest posture without all of the bells and whistles. I see some people's myo kits and I'm like, oh my gosh, I would go broke if I put that much stuff in we treat a large volume of patients here.
I'm probably one of them. My myo.
I literally have like a tiny little baggie with like a couple of like straws and a couple of elastics and a few odds and ends of things. And that is literally it. It's rare that I feel like I need any type of spot reminder. Now, I will have people sit for long periods of time, maybe with an elastic in there. And the reason I like the elastic over like the Coloplast or a Myospot is because if your tongue moves, that elastic moves too. Whereas if you have something stuck to the incisive papilla, if your tongue drops down, there's no consequence for it. And so your brain is not going to be nearly as alert to that tongue movement. And so I want something in there that is going to move if their tongue moves. And so that's why if we're doing, some training of good tongue posture for longer and longer periods of time, I actually prefer to use an elastic. And I don't treat super small kids. So obviously I'm not going to have a 4-year-old do an exercise like that. But for some of my like elementary and middle school kids and my teens and adults, while you're sitting there doing your homework or while you're watching something on Netflix, pop that elastic in and, remind that tongue to stay there. So I do activities that involve holding something on the spot, but I want it to be something that is going to fall down if that tongue does too.
That's a very good point. A lot of the courses that I take are from Brazil. So they're all taught by speech pathologists, and they use a lot of sweets, a lot of food, a lot of chocolate. And the hygienist was like, oh my gosh, really? And I actually just made it today. Let me get it. This is awful for a hygienist, but this is part of my therapy now.
Oh, is it like little runts or something?
Mini M&Ms.
Mini M&Ms, I love it. Yep.
So you hold the mini M&Ms on the spot, and the top fell off. And sour candy to stimulate saliva production.
Right.
It's awful, but not every patient, every parent will allow it. I usually ask because most of our patients actually are more holistic and are more like, no, we don't need sugar, we don't need dye.
Right,
So
exactly.
it's difficult, or children have allergies. But once in a while, I notice that with certain children like my own, a little bit of a sweet motivation gets her to actually do it. So I have her just hold the, okay, you want some mini M&Ms? Here is 6 because she's 6 years old. I have always done stuff because of her age. So you have to hold it on your palate with the tip of your tongue until it melts and you can eat it.
Right. And you know what? Like, chocolate is a great motivator. Like, this isn't for our patients, but this is like the therapist stash over here in this drawer. Like, we can't get through the day without chocolate working with these kids. So it's okay for them to have a little bit too while they're actually like doing the myo. So
whenever you spend, you have that day in the office, there's just, it goes over a little too long, I will find myself grabbing one of these.
I know. Sometimes you have to like embezzle the M&Ms from your own business because it's a survival technique. Yeah.
But so I guess with the question with your son gagging, is he gagging because of texture? Is he gagging because of a flavor? Just yesterday, I saw a patient that it's one of those patients that allergic to everything, and the parents don't allow any sweets and any of that. We did, they did meat. They cut meat in little tiny pieces, and she was holding the meat with her tongue up there.
Right.
So you kind of have to see what your child likes and what do you think is going to motivate them. And if you're scared that they are going to swallow the elastic, you can always tie a piece of floss. Tie a piece of floss and have them hold the floss, and they can even, move it.
That's excellent. Yeah, I even have them tie the floss sometimes onto the bite block because some parents are a little bit nervous about a bite block. But that's a great idea. Or, sometimes what I'll do is I'll buy the fruit leather and have them tear off a little piece of that because it's nice and flat. If you put a Cheerio in there, sometimes it sticks up a little too high. And especially if I'm having them do like water swallows and I want them to keep their tongue on the spot, I may have them using a little bit of fruit leather instead. So, there's more than one way to skin a cat. So you can usually learn how to modify it for whatever your patient's needs are. But I think the most important thing to remember is, I don't start out with like spot reminders for people on week 1. I'm taking care of that in phase 2, only if I still need to at that point. But if you sequence your treatment well enough and you are doing everything that you need to in phase 1, by the time they get to the suctioning, swallowing part in phase 2, they're already habituated with their rest posture. And so if you learn how to do it well, you don't need to do a lot of that other stuff. And that's why, I'm glad that I was taught in the dark ages of Myo 10 years ago, because I know how to do that. And a lot of therapists don't. I feel like, one of the problems that I see is that there's this watered down version of Myo where everybody's like, oh, like a couple like tongue pops and a couple like lip things and a Myo menchie and we're good to go. And the scary thing is that a lot of our dentists are thinking that that's all there is to this. And they're having their dental assistants do some things. And man, you want to get me started on how that's not okay. We're going to take another 4 hours to talk about that. That is absolutely unacceptable. Yeah. And we're missing the underlying art and science of what we as therapists are really trying to do. This is not about let's chew a few things and do a couple tongue suctions. There's so much more to treating oral muscle dysfunction than that. And so, that's one of the drawbacks of this field growing so fast is that there's a lot of dental offices that are claiming to do Myo, and it's, nothing more than a tiny little appliance and maybe 3 different exercises. And patients think that they're getting myofunctional therapy and they're not. So
it's not. It does. It really, really hurts our field, and it hurts the people that are doing this the right way, that are serious. Just and I think I can even compare it to several years of research on frenectomies, on tongue tie releases, and how, so many medical professionals it doesn't work. All the research shows that it doesn't work. Yes, but none of that was done with therapy. It was, we all know that just cutting the tissue is not going to do much.
It's not going to do anything. Exactly.
Before and after. So all of that research saying that no, it did not work. Well, what is it called? The tracheotomy?
Yeah.
Was 100% success rate for sleep apnea.
Right.
It's beautiful. Yeah. But are we going to be doing that to everybody?
Exactly. That's the thing is we're not looking at the right things. We're not looking at the right parameters to success. And so that's, that was beautifully stated. Yeah.
Very nice. Let's see. We have a few more questions. This is a good one. What about tongue sucking elimination program?
I love
tongue sucking. It's tough.
It is tough. So here is what I have found with every tongue sucker that I have ever treated, and I have had a handful of them. That is the one oral habit that I don't address first. In every other oral habit, we take care of the thumb sucking first. We take care of the finger first. We take care of the, chewing on the shirt collar first. But tongue sucking, every single time I've just jumped right into phase 1 of treatment, correcting the oral rest posture. And by the time we get to phase 2, where we're working on suction, chewing, swallowing, the habit has gone away by itself. So if we focus on keeping the tongue and the palate having the appropriate amount of freeway space between the jaws, 2 to 3 millimeters, and having the lips gently sealed, nasal breathing. If we focus on those principles, then those sucking habits of the tongue will start to be gone. They'll go away on their own, even if it's a nighttime habit.
Wow.
So, and again, make sure that you're establishing a good patent nasal airway before you start, because that may play into it as well. But yeah, so it goes away on its own.
Perfect. Let's see if I have any more. I like to use both elastic for active reminders and adhesives for passive reminders. You girls are a dream to listen to from London, UK.
Oh, thank you.
That's so sweet. Chris said, I agree with you about the watered down Mayo.
On the watered down Mayo thing. Yep. It's because she's a real therapist who knows like what she's doing. And, so for those of us who have been in the trenches and have rolled up our sleeves and done this work, to see some of what's happening is a little frustrating. And it's heartbreaking too, because it's a disservice to the families that we're trying to serve.
Definitely. Chris says rest posture is key with tongue suckers.
Absolutely.
And somebody asked, what is tongue sucking and tongue?
Okay. Yeah. So tongue sucking, it's usually, I have a video I wish I could show you guys, but it's often kind of a back and forth motion of the tongue. Sometimes you can hear it in somebody's sleep where it just sounds like they're just actively sucking on their tongue, or sometimes they're sucking on the lower lip. Yep, exactly. And so you can kind of see this back and forth motion of the tongue. And often it happens at night, but sometimes I see it during the daytime too. And then tongue thrust. Yeah, somebody was asking what a tongue thrust is. So tongue thrusting is just basically kind of a catch-all term, I feel like, for a dysfunctional swallow. So whenever we have a good, healthy swallow, the tip of the tongue is going to anchor on the spot or the incisive papilla. We're going to get our tongue that lifts up to the palate.
I'll demonstrate as you speak.
Well, beautiful. Renata's going to show us. And then that's going to create that pressure change necessary for the swallow. And so anybody who's a tongue thruster, they may have a tongue that's sort of, pushing forward anterior in the mouth. It may be lateral, either unilateral or bilateral. I see people that kind of retract their tongue back and bunch their tongue. Some of my people with more of that submucosal restriction tend to kind of retract the tongue a little bit. And then you hear the boom as they swallow. So there's all different kinds of dysfunctional swallows. But the thing that I always want people to know with a tongue thrust is it is just a symptom. It's just a symptom. If somebody has a dysfunctional swallow, it's our job as therapists to figure out why. You can correct a swallow. You can change a swallow by all sorts of creative ways. I mean, let's face it, crib and rake appliances change swallows, and they appear to eliminate an anterior thrust of the tongue. But just because you changed the swallow does not mean that you actually fixed the swallow, and you absolutely did not fix the oral rest posture, which if you look at the science, that's the part that matters more than anything. And I know that some of my speech friends don't like to hear this, but rest posture matters more than function itself, because that's where we have that long, light, constant pressure against the bone, and bone remodels by light, constant pressure. It does not remodel by heavy intermittent forces. And that's where, if we're just hyper-focusing on the tongue thrust, and trying to make that look different, we're missing the boat. We're not fixing the actual problem. So the rest posture it trumps everything else. Function's important. It absolutely is. But rest posture, when it comes to growth and development, matters more.
Definitely. If you think about ortho, I usually tell my patients, if you think about orthodontics, that's how they move teeth successfully.
Absolutely.
And your oral rest posture, so your tongue being up there, is what's going to initiate your swallow, what's going to initiate your speech. So usually, if your tongue is in the right spot to start with, you're more likely to do the function correctly.
Yeah, absolutely. We always start our speech production from where our tongue rests from. So if you've got this floppy flounder on the floor of your mouth, that's where you're going to start your sounds from. And all of our speech happens in the upper hemisphere of the mouth. It all happens in areas on the top jaw. And so you got to fix that, that underlying breast posture issue first. So, Zombeck, I love you too. And hi, Karen Masters, one of my Mayo besties.
Yes, and see, I'm going to put it up there, Karen. This SOP friend is all about rest posture. Leads
Yes,
our
she
speakers
is.
on the road
She
to
knows
fast.
what's up. Yeah.
Great. Very, very good. Angie, do you see people on telehealth? How can we get in touch with you? Do you have any courses coming up?
Yes.
I know that you have some amazing products on your website. Tell us a little bit about that.
Yeah. So first of all, I'm old school. You know, I love telehealth, but only for my established patients. So I still require, even through the pandemic, people still safely came to see us in person for their initial evaluation because
Same here.
I'm very much a hands-on. I got to get my fingers in there. And we do, other stuff. I do some TMJ muscle work on a lot of my patients, especially my chronic pain patients. So I've got to see people in person. So if somebody wants to come to us for therapy, they do have to make the trip to our office in Pennsylvania first for a full assessment. And then we can do telehealth for most of their sessions. And then they have to come back one final time for follow-up measurements, photos to kind of assess and make sure that we've hit all of our goals before we cut them loose. But we are always taking new patients. I have 2 other fantastic therapists who are working with me. We're looking at adding a 3rd one probably sometime this summer. And so, we're growing. And so my lovely ladies here at my office can take care of all of the patients that call. And I'm seeing patients actively as well, but hopefully this summer I can scale back a little bit because I am working on putting out some content. So I've taught live plenty of times in the past. And everybody's always like, come on, Angie, do some online stuff. And it's not that I haven't wanted to, guys. I really have. I just love that face-to-face interaction. But you know what? The world has changed. And even though I'm an old lady, I got to change with it. So I'm putting out content online. I finished filming kind of an intro to Myo class. So anybody who's heard me, speak for like my 1 or 2 hour lecture on just the nuts and bolts of Myo, it's kind of my crash course. That should be available sometime soon. They can find it on my website, omtofyork.com. And then I am being really intentional about putting together some really fantastic content that is all intermediate and advanced level stuff for therapists, because I'm not okay with this watered down version of Myo. And so if you're a therapist who feels like, wait a minute, am I missing something? Do I need more knowledge about how to actually treat the muscle dysfunction? That's the role that I like to see myself filling. And so I love to teach people hands-on assessment. I love to talk about craniofacial growth and development. I love to talk about just how muscles develop and how if we understand how muscles develop, then we can understand the right sequence to fix muscle dysfunction in. So I'm putting together some content for that. And then just talking about building our team and how to interact and talk to all of these other professionals, how to speak the same language as them, and how to get them to understand that this is not hocus pocus, that there is real science behind what we're doing. So, that's going to kind of be the series of content that I'm going to be putting out over the next couple of months. Intro level stuff other than that, quick little video, just because there's so many people out there that are so darn good at it that I don't need to recreate the wheel. So I want to do something that people feel like they need. And so I'll be working on that this summer and getting some stuff out. So
awesome.
York.com, go find it. You can find all of our products. We've got brochures. We've got a game. We've got some stickers, all sorts of products to help therapists. And I will say, I have not made this announcement publicly yet.
Airway Circle first.
You're the first one to hear about it, Renata. So 2 things. People have been asking me for a couple of years to put out a brochure on tongue tie. And I've been hesitant because there's, a lot of what we experience in therapy, and then there's actual science that we can look at. And so I have been waiting because I could just never quite get the wording right. And so that brochure, I finally have put it together. And actually I sent it to Karen Masters already to proofread because she's my boots on the ground, tell me what I'm forgetting. And she gave it the thumbs up. So that one should be coming out in the next couple of weeks. My designer that I use just had a baby. And so I'm just waiting for one more little thing for her to change on it. Yeah. And then I can roll it out. And the other thing is that I have had some feedback from people on our brochures. They love the content. And you know that I'm a certified orifacial myologist, and I know that you're like right in the middle of like finishing your certification too. And I love that, and I'm proud of it. But I recognize that there are other ways to be really successful in this field. And so in the past, our brochures have always been, you know, using the wording certified orifacial myologist. And we have changed it to be certified orifacial myologist / myofunctional therapist, because I realize that there are some men and women out there who are phenomenal therapists who aren't going to go through the same certification process that I did, but still deserve to have really good information. And so all of our newer brochures that we're having printed right now are all inclusive of everybody who's working in this field. So hopefully that will help some people who have been hesitant to purchase our products in the past.
That is wonderful. Well, thank you, thank you, thank you. My goodness, we seriously could sit here for a couple more hours.
I know. We could do this for hours. Yeah, but it's a beautiful day. So people need
to this is so much fun.
Start their
Everybody, thank y'all for being here. Thanks for joining us on this Friday afternoon. Angie, I cannot be happier than that you were accepted our invite and you were here and you gave so much this last hour. Thank you so much, and I hope that we can collaborating, working together. Airway Circle is here to share this message that we all have in our hearts to be able to help more patients achieve optimal health. So thank you for being part of it.
I love it. It was my honor. Thank you so much.
Thank you. Bye, everybody.